So we looked at the sodium HF trial, which studied in a dietary sodium intervention in patients with heart failure. And that trial, which was completed and had a full setup of over 800 patients in 6 countries, we wanted to look at whether or not the treatment effects of dietary sodium as an intervention varied across people's different risk profiles. That is, if there were different risks for an eventual outcome, such as heart failure hospitalization or cardiovascular death or all-cause mortality, did the intervention have a difference on in how it played out? And so our goal was to really explore this using something called heterogeneity of treatment effect, which is a different statistical technique than our usual multivariate modeling and other techniques. So I think clinicians are wise to the fact that when an overall primary endpoint is neutral, they should also not throw away that scientific information that was gained from that trial, because we can often learn a lot about a secondary analysis, subgroup analysis, to point us in the direction of what we may recommend, or alternatively, what should be studied in the future. In this case, we saw the overall primary was neutral. We had some key secondary endpoints which showed some benefit in quality of life for patients on a lower dietary sodium compared to a control. But that is hypothesis generating at its best. So the way what we took away from the overall trial when we saw that was that for some patients there may be a loosening of recommendations around dietary sodium as an intervention, and that it may, for some patients, improve quality of life, but it doesn't change the clinical events such as cardiovascular death or all-cause mortality or heart failure hospitalizations. Now, when we go to look at that in a secondary analysis, in a subgroup or secondary analysis, depending on which is important, we really want to explore that, because sometimes we say, well, the overall trial is neutral, but can we get any other information? In my kind of way of thinking about this, is hard to throw away the voluntary participation of 800 participants in a trial and not use that information wisely for the next set of patients to come along, to hopefully inform them. Even if it's a softer recommendation, we can still provide some insight into fill in some of the knowledge gaps we already have. When I look at what we've done in this analysis, we've identified that the intervention and its outcomes did vary across different risk quartiles, and we used the magic risk score to really understand that risk of a patient's future event. And we identified that the patients at the lowest overall risk for a future clinical event had the greatest effect size for dietary sodium intervention. So that is, people at low risk seem to get all the benefit, and people at the highest risk didn't seem to get any of the benefit and maybe even potential harm. Difficult to say there's any real harm, but what we want to identify is there's a difference in spectrum of the outcome. Well, I definitely think we should rethink uniform recommendations for dietary sodium as an intervention. The largest trial we've ever done in this area is, in fact, the sodium HF trial, and it shows that it was neutral for a clinical outcome. So if that is our benchmark for what we implement in clinical practice, then we shouldn't make broad sweeping recommendations for all patients. Now, that recognizes that we don't operate in a vacuum, and we should really think about the next trials that need to be done. And I'm hoping somebody comes along and does a twice as large or 10 times larger trial and proves us wrong. I want us to see that we're doing the best thing for our patients. The broad recommendations from a guidelines committee have implications for patients. One of the ways I frame it is, if a clinician is seeing a patient, the clinician is recommending something, and a patient has to be the one to implement that and go out and shop for whatever food products they need to buy to meet that recommendation. That comes with a cost, a financial cost, a time cost, but also a lot of guilt if there's a recommendation they can't seem to follow and they do have worsening symptoms or outcomes. That there may be some guilt that they take on because they don't feel like they're doing everything they can. I do think we should really be more flexible in our recommendations regarding this now from dietary sodium as an intervention, as we've not shown it to be dramatically beneficial for patients in the best setting we could create. Absolutely. So the way I would counsel patients now, after doing the sodium HF trial and walking through that entire trial and how we did it and all the menus and all the things, I do recommend this for some patients if they want to follow a lower sodium diet overall. I think it's a great part of their overall health, and they should think about it as an overall health strategy rather than strictly counting each crystal of salt, which is, they think is going to be linked to their quality of life. That said, if I am recommending it, I also couch it in the terms of, this could improve your quality of life, or be related to your quality of life, and that's how you should view it. Um, I also couch it in the terms of, telling people that there's, hills and valleys and how food is consumed. You may have one day have more, one day have less. That's okay. Don't get bent out of shape about it. It's more important that you have an overall healthy diet and work towards those healthy goals you have. Yeah, we often say things in the manuscript that we know are hard to implement and do, and this is one of them. Embedding HTE into a clinical trial where we adapt it based on the treatment effect size anticipated and the risk based treatment effect size that we're anticipating is actually quite tricky. You have to have a lot of information about the patient up front to get that risk correct and be using the right risk estimator as a risk score of whatever one is chosen. And then also that has to be tightly coupled to the outcomes of those patients for that duration of therapy. So not easy. I still like large, simple, pragmatic trials because they answer a question that clinicians and patients want to answer. So it may be that embedding an upfront risk score in the front end of the trial would help. And in fact, that's probably what we would end up doing if we were to do it all over again, is to improve some risk stratification as a tool. It's not the easiest thing to do in a trial, but it is definitely feasible in the bigger picture.